Okay, welcome everyone. We are here with Daniel, and you're going to talk about sharing blood test results.
Yes, thank you. All right, so this is a quite interesting project, first of its kind in Israel. And so a little bit about me. I'm the founder and CTO of Outburn. We're mainly a consultant company. We help implement FHIR in Israel. In this project, we designed the solution. This is a joint initiative of the Israeli Ministry of Health, the FHIR community, Sheba Medical Center, and Meuhedet Healthcare Services. It was funded by a grant by FHIR. The main goals are to reduce the bureaucratic burden on oncology patients and their families, accelerate interoperability adoption in Israel, and creating a national IG for FHIR-based sharing of lab results between HMOs and medical centers. So potentially it will not be limited just for oncology, but that was the major use case we started with. So a little bit about Sheba Medical Center. It is ranked by Newsweek among the 10 best hospitals in the world. 4 years in a row already. It's an international leader in medical innovation, and it is collaborating with health centers around the globe to develop technologies and life-saving treatments. The oncology daycare services there, they provide all types of treatments, including chemotherapy, immunotherapy, and personalized therapy. They have 3 units there, 300 daycare treatment, and 160 patient positions, 80,000 visits per year. And the other side of the project is Meuhedet Healthcare Services, which is the third largest HMO, has 1.3 million insured patients. And they have around 1,000 nurses, 130 pharmacies. They have a hospital called Misgav Ladach, 4,000 doctors, 400 clinics, 120 dental clinics. And this is the problem statement. So oncology outpatient treatment, we have around 140 patients a day that need to undergo blood tests within 24 hours before the treatment. To perform these blood tests, they must contact their HMO and have their GP request the lab to perform the test. And the patient must ensure the results are obtained before arriving at the outpatient clinic and present them to the hospital. And only then, when the patient is already there, the care team can decide whether the treatment can take place. And this is the real problem. So the impact of it is that the patient is a messenger. And if the tests are incomplete, he's going to have to do retesting in the hospital. And the result interpretation, which is done by the care team, they may lead to the cancellation of the treatment. So it's a waste of a whole day for that patient. And if they have limited technological proficiency, they may actually struggle getting the actual results from the HMO app. On the practitioner side, it's a huge administrative burden to search and retrieve the results. There are a lot of quarrels arising from the patient's frustration, treatments canceled or delayed at the last minute. And on the hospital side, it's many staff members that are required to do all of this bureaucratic work. A lot of unused medications that they must be thrown away. And those last-minute cancellations make it really difficult to manage the scheduling, and they have wasted slots, which affect the overall wait times. So overall, the solution is something like that. So the hospital creates a service request, a referral, on the HMO server. And then on the HMO side, they create an internal referral in the lab system. They perform the lab test, generate the result, send the result and the report to the hospital. And in the hospital, the care team can view the results on a dashboard. I'll show you the dashboard in a second. And then they can decide and notify the patient. So he would not need to come if the tests are not in the correct boundaries. So this is the dashboard. I'm sorry about the Hebrew, but overall what you can see here is they can look at the list of patients that are scheduled for that day, and the colors indicate if the results are in range. There are two ranges here. There is the range of the HMO, and there is the range of the hospital. There are different reference ranges, but they both give them important information in the decision. And so we choose a patient, and we can see that some of the tests are okay, some of them are outside of the reference range of the HMO, and the red ones are the ones that are outside of the reference range of the hospital. Now, they can still make a decision that it's okay and the patient can come. This is a human decision, not automatic. So yeah, those are filters, and exactly this is just what I showed you. Yeah, the green normal results outside the HMO. All right. So architecturally, we had a few guiding principles here. So first of all, the communication is entirely based on FHIR. This is what the grant is all about. Internally, in the hospital and the HMO, we are reusing existing interfaces. So the lab interface and everything that's internal is still as is. And each party is both a server and a client, which is something that we tried to avoid, but eventually it was the right decision because it's, each side needs to be active in this workflow. They don't want, the HMO doesn't want the hospitals to poll the server like every few minutes or every few hours. The results need to be sent to the hospital as soon as possible. So yeah, so we have a server and a client in each side. And we use conditional interactions and references because once you have two servers and the same resources shared between them, the logical IDs differ. It makes it pretty complex. So the solution is entirely based on business identifiers with conditional interactions. So there's an implementation guide. It's published. We have generated it using the IG publisher. It includes all the profiles, code systems, value sets, extensions, also workflow and data flow diagrams, and general guidance for how to implement this, all the interactions, the search parameters, etc. And there's a link to the IG. Again, sorry that it's Hebrew. So this is the general data flow. I will zoom in. So what we have here, the medical center starts as a client, and the first thing they do is get patient, which is of course by the IL core patient profile, and it's a little bit small for me here. And then they get either an empty bundle or a bundle with a patient resource, and they post the service request or a series of service requests, and the server, in the end, the HMO server receives it and starts the testing. Then they act as a client, the HMO, and they post an observation to the server of the medical center. They may also update that observation, and they post an update to the service request and a diagnostic report at the end. So that would be the data flow. So the next steps, we are planning to expand this to other types of laboratory tests, not only oncology, and to roll out the solution in additional hospital units, and of course other HMO. We have 4 HMOs in Israel, so it's potentially, once we have that in all of them, then all of the citizens of the country can enjoy this service. And of course, it's a win-win-win. So for the medical center, they are saving manpower, they are streamlining the queue management, they reduce patient load, optimal utilization of medications. For the patient, it's less bureaucracy, shorter waiting times for treatment. That actually affects all the patients, the waiting times. Preventing unnecessary hospital visits and reducing the frustration. And for the HMO, reducing the overload, the workload of the GPs. Of course, innovation and improved service. So I think that would be it. If you want to talk to me, you can contact me. That's my email. I have here a link to my LinkedIn. And time, I guess, for questions. I don't have a slide for questions, but...
Any questions?
All right.
Well, it was a clear talk then.
Yeah,
Thank you, Daniel.
Thank you. Thank you very much.